I want to talk to you today about something personal, something I say to my patients when I sit across from them in my office, and they mention it almost as an afterthought. Oh, and I take a sleep aid sometimes when I cannot sleep. And I ask them what they take, and they tell me the name, and I pause, and I look at them, and I say, I need you to stop taking that, and let me explain why. Because the sleep aid I am talking about is one that millions of seniors over 65 take regularly. Some every night, some a few times a week, and almost none of them have been told what it actually does to the brain. After 65, what the research now shows about its long-term effects on memory, on cognition, on fall risk, and on the very sleep quality it promises to improve. I am Dr. Daniel Chen, and today I want to talk to you about diphenhydramine, the active ingredient in some of the most widely used over-the-counter sleep aids in America, including ZzzQuil, Unisom sleep tabs, Simply Sleep, and the PM versions of many common pain relievers, including Tylenol PM, Advil PM, and Benadryl. Now, diphenhydramine is not a medication that was designed to be a sleep aid. It is an antihistamine, originally developed to treat allergies. Its sedating effect is actually a side effect of its antihistamine action, a side effect that pharmaceutical companies recognized and repackaged as a sleep product. And that is the first thing I want you to understand. You are not taking a medication that was designed to help you sleep. You are taking an allergy medication whose drowsiness side effect has been marketed to you as a sleep solution. And after 65, that distinction matters enormously, because what diphenhydramine actually does inside your brain is not what the packaging suggests. So let me explain. What diphenhydramine actually does when you take it. Diphenhydramine is a first-generation antihistamine. It works by blocking histamine receptors throughout the body, which is why it reduces allergy symptoms. But histamine is not just an allergy chemical. In the brain, histamine is a neurotransmitter, one that plays a critical role in maintaining wakefulness, alertness, and cognitive function. When diphenhydramine crosses the blood-brain barrier, which it does very readily, much more readily than newer antihistamines like cetirizine or loratadine, it blocks histamine receptors in the brain. This is what causes the drowsiness. But it also does something else, something that most people do not know. Diphenhydramine also blocks another neurotransmitter system in the brain called the cholinergic system, the system that depends on a chemical called acetylcholine. And acetylcholine is arguably the most important neurotransmitter for memory, for learning, for attention, and for cognitive processing. It is the neurotransmitter that is most severely depleted in Alzheimer's disease. And diphenhydramine, by blocking acetylcholine activity in the brain, produces what doctors call an anticholinergic effect. Now, here is why this matters so profoundly. For people over 65, as we age, the cholinergic system naturally weakens. Acetylcholine production declines. Acetylcholine receptor sensitivity decreases. The brain's ability to maintain adequate cholinergic neurotransmission becomes less robust. This is a normal part of brain aging, and it is one of the reasons why memory and processing speed change somewhat with age, even in perfectly healthy older adults. Now, when you take diphenhydramine, you are adding a pharmacological blockade of acetylcholine on top of an already weakened cholinergic system. You are suppressing a neurotransmitter system that your brain is already struggling to maintain. The result in older adults is a cognitive suppression that goes far beyond simple drowsiness in older adults. Diphenhydramine commonly causes significant next-day cognitive impairment, even after a single dose. Confusion, memory gaps, slowed thinking, difficulty concentrating, a foggy, heavy feeling that can persist not just through the night, but through the entire following day. And because these effects are subtle and gradual, and because they can mimic the normal cognitive changes of aging, many older adults have been experiencing diphenhydramine-induced cognitive impairment for months or years without anyone connecting it to the sleep aid they have been taking. Now let me talk about the research, because this is not speculation. This is documented in peer-reviewed medical literature. The JAMA Internal Medicine Journal published a landmark study that followed over 3,000 older adults for an average of 7 years and found that cumulative use of anticholinergic medications, including diphenhydramine, was associated with a significantly increased risk of developing dementia, including Alzheimer's disease. The risk was not small. People who had taken anticholinergic medications at the level of diphenhydramine for 3 or more years cumulatively had a significantly higher risk of developing dementia than those who had not taken them. Now, I want to be precise here because precision matters in medicine. This study showed an association, not definitive proof of causation. Research in this area is ongoing, and the picture is not yet complete. But the association is strong enough and consistent enough across multiple studies that the American Geriatrics Society, the Beers criteria, which is the most widely used clinical guideline for medications in older adults, specifically lists diphenhydramine as a medication to avoid in adults over 65. Not to use cautiously, not to use at a lower dose, to avoid, and specifically notes the cognitive risk as the primary reason. This is not a fringe position. This is the mainstream recommendation of geriatric medicine, that most general practitioners simply do not have time to communicate to every patient who mentions taking a sleep aid. Now, let me also talk about the fall risk, because cognitive impairment is not the only concern with diphenhydramine in older adults. Diphenhydramine causes significant sedation that in older adults does not simply produce a clean night of sleep and then wear off cleanly. The half-life of diphenhydramine, the time it takes for the body to clear half the medication, is significantly longer in older adults than in younger adults, because the liver and kidneys, which process and excrete the medication, are less efficient after 65. What this means is that when you take diphenhydramine at bedtime, you are still significantly affected by it when you get up in the night to use the bathroom, or first thing in the morning when you stand up. And that sedation, combined with the muscle relaxant effects that diphenhydramine also has, combined with the orthostatic hypotension, the blood pressure drop on standing that is already more common after 65, creates a combination that is one of the most significant medication-related fall risk factors in older adults. Research has consistently shown that use of sedating medications, including diphenhydramine, significantly increases fall risk in older adults. And falls in adults over 65, as I've discussed in previous videos, are not minor events. They are the leading cause of injury and injury death in this age group. A hip fracture following a fall that was contributed to by a medication taken to help you sleep is a devastating outcome that could have been prevented. Now, let me also address something that I think is important and honest, and that I know some of you will be thinking, but Dr. Chen, diphenhydramine actually works for me. I take it and I fall asleep. And I hear that, and I understand it, and I am not dismissing your experience. Diphenhydramine does produce sedation that feels like it helps you sleep. And in the short term, a single occasional dose helps many people fall asleep faster. That part is real. But here is what research on sleep architecture shows about what diphenhydramine actually does to your sleep. Beyond just helping you fall asleep, diphenhydramine suppresses REM sleep, rapid eye movement sleep, which is the stage of sleep most critical for memory consolidation, emotional processing, and cognitive restoration. it also suppresses slow wave sleep, the deepest and most physically restorative stage of sleep. So while diphenhydramine helps you lose consciousness and stay sedated, it does not produce the sleep architecture that your brain and body actually need. You feel like you slept, but your brain did not get the sleep it needed. And over time, this matters because the suppression of REM sleep and slow wave sleep night after night has its own cognitive and physical consequences, independent of the direct anticholinergic effects of the medication itself. So the sleep aid that feels like it is helping you may actually be suppressing the very stages of sleep that your brain most needs, while simultaneously suppressing the neurotransmitter system most critical for your memory and increasing your risk of falling when you get up in the night. That is a high cost for something that feels helpful. Now let me talk about what actually helps with sleep in older adults, because I am not here to take something away from you without offering something real in return. The first and most evidence-supported approach for insomnia in older adults is called cognitive behavioral therapy for insomnia, or CBTI. CBTI is not a medication. It is a structured therapeutic approach that addresses the thoughts, behaviors, and habits that perpetuate poor sleep over time. Research has consistently shown that CBTI produces better long-term outcomes for insomnia in older adults than any medication, including prescription sleep medications, with no side effects and with improvements that persist after the treatment ends. Rather than creating dependence, CBTI can be delivered by a trained therapist through an online program or through structured self-help resources based on CBTI principles. Ask your doctor about CBTI if you have not already. It is the first-line recommended treatment for chronic insomnia in all major clinical guidelines, including those specifically for older adults. The second approach is melatonin, but with an important clarification about dose. Many older adults who take melatonin take doses of 5 or 10 milligrams because those are the doses most commonly available in pharmacies. But the research on melatonin in older adults consistently shows that very low doses of 0.5 to 1 milligram are more effective than high doses and produce fewer side effects. This is because after 65, the pineal gland, which produces melatonin naturally, is more sensitive to supplemental melatonin and responds more effectively to small amounts than the doses most people are taking. If you have tried melatonin and found it did not help or caused next-day grogginess, it may be worth trying again at a much lower dose of 0.5 to 1 milligram, taken about 30 to 60 minutes before your intended sleep time. The third approach is addressing what is actually driving the sleep problem. In many older adults, poor sleep is a symptom of an underlying cause that has not been identified or treated. Sleep apnea, which is significantly underdiagnosed in older adults, is one of the most common drivers of fragmented and unrestorative sleep and is entirely treatable with appropriate therapy. Nocturia, getting up multiple times to urinate, which I have discussed in a previous video, is another common cause of fragmented sleep that often has addressable contributors. Chronic pain, anxiety, depression, and medication side effects are all common contributors to poor sleep in older adults that deserve clinical attention rather than a sleep aid that covers the symptom without addressing the cause. The fourth approach is sleep hygiene. And I know that sounds basic, but the evidence for specific sleep hygiene behaviors in older adults is genuinely strong. Consistent wake time every morning, regardless of how poorly you slept, is the single most powerful sleep hygiene intervention, more powerful than consistent bedtime because it anchors the circadian rhythm. From the wake side, light exposure, particularly natural sunlight, within the first 30 minutes of waking, as I discussed in my sleep videos, helps anchor the circadian clock and improves nighttime sleep quality over time. Avoiding naps longer than 20 minutes, particularly in the afternoon, and avoiding caffeine after midday are both well supported by sleep research in older adults. Now let me bring everything together. Diphenhydramine, the active ingredient in ZzzQuil, Unisom sleep tabs, Tylenol PM, Advil PM, Benadryl, and similar sleep is an antihistamine whose drowsiness side effect has been repackaged as a sleep product. After 65, it carries 3 serious concerns that most people taking it have never been told about. First, it blocks acetylcholine, the neurotransmitter most critical for memory in a brain that is already producing less acetylcholine due to normal aging, producing significant cognitive suppression that can mimic and potentially worsen age-related cognitive decline. Second, research including a landmark JAMA internal medicine study has associated cumulative anticholinergic medication use with a significantly higher risk of dementia, including Alzheimer's disease, leading the American Geriatrics Society to specifically list diphenhydramine as a medication to avoid in adults over 65. Third, its prolonged sedating effect in older adults whose livers and kidneys clear it more slowly significantly increases fall risk at night and in the morning when the body is already most vulnerable. And the sleep it produces suppresses REM and slow wave sleep, the very stages most critical for cognitive restoration and physical recovery. The alternatives are real. CBT1 is the most evidence-supported treatment for chronic insomnia in older adults, with no side effects and lasting results. Low-dose melatonin of 0.5 to 1 milligram is safer and often effective for sleep onset, addressing underlying causes of poor sleep, including sleep apnea, nocturia, pain, and anxiety, is more effective than any sleep aid. And consistent wake time, morning light, and basic sleep hygiene provide genuine benefit with no risk. If you are currently taking any product containing diphenhydramine for sleep, please bring this up with your doctor. At your next appointment, tell them what you are taking and ask specifically whether there is a safer alternative. Given your age, you deserve to sleep. You also deserve to sleep safely and to wake up in the morning with your memory, your balance, and your brain fully intact. I am Dr. Daniel Chen. If this video gave you information that you did not have before, please share it with someone over 65 who takes a sleep aid regularly and has never been told about these risks. It could genuinely protect their brain, their balance, and their independence. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health. And leave me a comment below. Tell me what sleep aid you have been taking and how long you have been using it. I read every single comment, and I genuinely look forward to hearing from you. Take care of yourself tonight, and take care of your brain every single night.